Hi guys, welcome everyone. So we are continuing our one more Farre topic today, that is emergency medicine. I will be addressing two major questions, and within that we will have multiple subtopics to be addressed, which can be minor questions of 5 marks or 3 marks. So without wasting our time, let us begin with the first question. Give me a thumbs up if you are able to hear me loud and clear. Okay, I'm just waiting for a confirmation that I'm audible. Okay, cool. So first question is on the poisoning. Organophosphate poisoning in itself is a 10-mark question, but we can also have a 5-mark question on aluminium phosphide poisoning as well as 10-mark question on paracetamol poisoning. And this is where we're going to spend most time. In the second part, we will talk about shock, including septic shock and other forms of shock. Okay. So if it is a 10-mark question asking us to write about various poisoning, how the marks will be distributed. Of course, organophosphate poisoning will carry 5 to 10 marks. Aluminium phosphide poisoning will always be a 5-mark question. Paracetamol poisoning can be 5 to 10 marks question. Okay, so we'll begin with the first, which is organophosphate poisoning. So what are organophosphates? Organophosphates are primarily used as pesticides, which are acetylcholine esterase inhibitors. Organophosphates used pesticides as pesticides are potent. They are potent, irreversible acetylcholine esterase inhibitors. Acetylcholine esterase inhibitors. Okay. So what problem it can lead to? So when in body, acetylcholine is used as a neurotransmitter, as we know, right? It is a neurotransmitter in various neurons. Apart from that, it is part of our parasympathetic nervous system. So all our parasympathetic nervous system's functions are executed by the acetylcholine. So once the acetylcholine does its job, right, it is a neurotransmitter, it is a neuromuscular junction transmitter, and it is a component of parasympathetic nervous system. Once it does all of its job, it will get degraded by an enzyme called as acetylcholine esterase to choline and water. Okay, and what organophosphate compounds do? OP compounds inhibit this acetylcholine esterase, right? So OP compounds are going to inhibit this acetylcholine esterase. So what is the result of it? It can result in cholinergic excess, right? So once there is someone who has consumed high or toxic doses of organophosphate compounds, it will cause cholinergic excess. So we are expecting the cholinergic crisis or cholinergic excess. So there will be cholinergic excess in these patients. So in all the tissues where acetylcholine is primarily used, we will start seeing the symptoms related to that. For example, in the parasympathetic nervous system, acetylcholine excess will lead to its parasympathetic consequences. Okay, then the use of acetylcholine by the neuronal communication. If I am blocking the acetylcholine esterase, there will be hyperactivation of the acetylcholinergic neurons. It will lead to its own set of symptoms. Similarly, neuromuscular junction, there will be increased stimulation of the acetylcholine receptors, which is primarily nicotinic, and it will have its manifestations. So when I have to write the clinical features, it is more wiser to divide the clinical features into muscarinic effects, nicotinic effects, and the CNS effects. So what CNS effects I can get? Excess cholinergic activity in the brain can lead to cerebral edema, right? Drowsiness, to coma, and it can also precipitate seizures. Those are the CNS manifestations. What are the muscarinic effects I get? The muscarinic receptors are primarily expressed in your smooth muscles. Where do I get smooth muscles? In your bronchial tree, right? In your intestines. And where else I get the smooth muscles? I get in blood vessels, right? Okay. Apart from that, muscarinic receptors are also active on the cardiac vessels. Okay, so I will have the impact of muscarinic effect on all these locations. Okay. Apart from that, muscarinic receptors are also expressed on the glands. So when gland secretions, there can be hyperstimulation. So what effects I'm going to get? I can get bronchoconstriction that can result in hypoxia, right? Okay, second, all the glands, okay, including the smooth muscles of iris. So there can be constriction of the pupil or meiosis. Second, next, there will be increased activity of all your glands. So there will be salivation, lacrimation. Okay, intestines also have smooth muscles. Smooth muscles are getting stimulated by this excess acetylcholine that we are getting by blocking the acetylcholine esterase. So there will be increased intestinal motility that can give rise to diarrhea or defecation. Then there can be emesis or vomiting. Okay, there can be urination, and apart from that, these patients can have bradycardia because of the excess activation of the parasympathetic nervous system. We remember the sympathetic nervous system stimulates and increases the heart rate and force of contraction of the heart, and parasympathetic does opposite of it. Parasympathetic decreases the heart rate. So if I activate parasympathetic, I will have decrease in the heart rate. So these are all muscarinic manifestations. Some of these manifestations can be remembered with the simple mnemonic sludge symptoms, where S stands for salivation, L for lacrimation, U for urination, D for defecation, diarrhea or defecation, okay, E for emesis, and G for increased gastric motility can also result in abdominal pain. You can say gastric symptoms or abdominal pain. So these are all muscarinic effects. The mnemonic to remember is sludge. Apart from that, I want you to remember bradycardia. It's the most important symptom that you need to write. And then the bronchoconstriction and meiosis. Okay. Apart from bronchoconstriction, secretions from the bronchial tree, the glands in the bronchial tree will also be increased. So patient can have what we call as bronchoria. What is bronchoria? Excess secretions from the bronchial glands, resulting in sometimes patients flood and choke in their own secretions. So simple words, OP poisoning patients start throwing out fluids or secretions from everywhere. Okay. What are the nicotinic effects? Nicotinic receptors are primarily expressed in the neuromuscular junction, right? So like when the lower motor neuron brings the impulse from the brain for the contraction of the muscle, right? The nerve terminal ends up releasing acetylcholine. This acetylcholine will go and bind its receptor, which is the nicotinic type of acetylcholine receptor on the muscle, and that will cause the contraction of the muscle. So all our muscle contractions are because of nicotinic acetylcholine receptor activity. If there is excess acetylcholine, it will hyperstimulate the acetylcholine receptors. So what is the outcome of that? Muscles may start contracting or twitching unnecessarily. So what we will call it as? We will call it as fasciculations. Fasciculations. Why fasciculations are happening? Because of the persistent or hyperstimulation of nicotinic acetylcholine receptors. But if I persistently stimulate the acetylcholine receptors, what will happen to the muscle? The muscle will start becoming weak. Why? To give you an example, right? Think of it. You go to gym, take a dumbbell, start lifting it. Can I do it infinitely? Not possible, right? Maybe I can do it 5 times, 10 times, 15 times, 20 times, maybe 50 times, 100 times. Somewhere down the line, I will not be able to lift the dumbbell anymore, right? That is the failure point or fatigue point. So during this process of lifting, my muscles are utilizing all the metabolic reserve they have, right? All the glucose, ATPs, glycogen, right? The substrates for the oxidative phosphorylation, all the metabolic reserve is being used. So I will reach a point where my muscles have used all their metabolic reserve and they do not have any metabolic reserve left. After that, my muscles cannot contract. When I take rest, my muscles will again rebuild the metabolic reserve and I'm ready for the next set in the gym. Same applies here. So if I hyperstimulate, I'm pushing the muscles to spend all their metabolic reserve, and then once muscles have spent their metabolic reserve, they are not left with sufficient metabolic reserve and they will not be able to contract. So it can lead to muscular weakness or paralysis, right? Muscular weakness or paralysis. And the process may affect the respiratory system also. So it can lead to respiratory paralysis. Respiratory paralysis. So in a patient with bradycardia, in a patient with OP poisoning, bradycardia and respiratory paralysis are the two things which are life-threatening. Okay, two things which are life-threatening, right? Because if there is bradycardia, you may not be able to generate sufficient cardiac output. You may not be able to perfuse your brain sufficiently, perfuse your kidney, liver sufficiently, and you will end up with organ failure. Many patients of organophosphate poisoning die because of organ failure, right? What is our formula for cardiac output? Cardiac output is equal to stroke volume into heart rate. So if I decrease my heart rate, what will happen to cardiac output? Automatically it will come, right? Second, if my respiratory muscles go into weakness, I will not be able to maintain the desired saturation because I'm not able to move the diaphragm and intercostal muscles that well. So I will succumb to hypoxia. So these two things contribute to the death in most of the patients: profound bradycardia and respiratory paralysis. So these are the clinical features of organophosphate poisoning. How do I describe? I will divide them into muscarinic, which I can remember with slight symptoms, nicotinic, which is related to neuromuscular junction. So you can simply remember it as weakness of all the muscles, and the respiratory paralysis. CNS, just write about the coma and seizures. So once I have a patient who is brought to me saying that sir, he has consumed some poison, it is most likely pesticide, they will generally bring the bottle. On the bottle, I will know the chemical name, right? And then from there, I can conclude that it is either organophosphate or organochloride. Clear. But many times what happens is patients are brought without the container or without the history of consumption of organophosphate compound. So in such cases, how will I take it for the diagnosis from here, right? So remember, another thing that I forgot to mention is that the organophosphates generally have strong, pungent, fishy odor. Strong, pungent, fishy odor. This odor is actually difficult to describe. You can't say fishy as such, but if you have been to a village, or if you are son of a farmer, or you have exposed yourself to farming activities, then you can recognize the smell pretty well. Okay. So organophosphate smell itself may be striking or alarming for many of us to recognize it as a organophosphate poisoning. In fact, I can share an experience. We had a patient who was brought without any history available, that family members noticed him restless. They got him to the hospital. In the hospital, he became drowsy. But an ECG was done, which was showing sinus tachycardia and some non-specific STT changes. And troponin I was done, it was weakly positive. So cardiologist suspected it to be a case of acute coronary syndrome. So he took to cath lab, and of course at that age of 55 or something, some degree of coronary occlusions will be there. He recognized them, took the corrective step, and then shifted back to the hospital. But of course, patient, because he was drowsy, to protect his airway, they had intubated. On day 2 or 3, there was a call for re-intubation because patient had extubated. And when I went there to re-intubate, there was a profound smell, and I could recognize it as organophosphate, being in close touch with farmers and farming, and having studied in a government medical college where organophosphate poisoning cases were so common, I could recognize the smell as organophosphate. So then I spoke to the cardiologist saying that, sir, I'm getting the smell of OP. He was not convinced. He's like, someone would have sprayed for insects or pest control in the ICU. But the smell was pretty strong, and there was the constricted pupil. So I again insisted, sir, smell is very particular, strong, and there is meiosis. So then reluctantly he said, okay, investigate. Now the question is, how will I confirm? Right? Well, I'm suspecting. How will I evaluate or confirm? So evaluation includes, the more ideal confirmation of organophosphate poisoning is the toxicological analysis, right? Either gastric aspirate, or if you have induced vomiting, the vomitus can be subjected for the toxicological screens, where the biochemical lab will study not only the organophosphate compounds but other possible poisons which a person is likely to take. That will be the ideal investigation. But one initial supportive clue we can get is from pseudocholinesterase activity. So we can estimate the serum pseudocholinesterase activity, or RBC pseudocholinesterase activity, if there is a patient with organophosphate poisoning. the activity of acetylcholinesterase and pseudocholinesterase will be reduced because organophosphate compounds inhibit their activity. So if there is reduced pseudocholinesterase activity, it is highly suggestive of, not specific, but highly suggestive of organophosphate compound poisoning in the right context. Now, what do I mean by right context? Where there is a history of consumption of something, or there is a organophosphate poison smell emanating from the patient, history of exposure or consumption, or that particular smell, and then I have low pseudocholinesterase activity, I can make a diagnosis of organophosphate poisoning on clinical grounds. Now, of course, for further confirmation or at least for medical legal purpose, the gastric aspirate sample needs to be sent to the lab for analysis. Okay. Apart from that, ECG is also required as an initial tool, not for the diagnosis, but to know the status of patient's cardia. So ECG often shows a degree of bradycardia, which we will document. Okay. Now, once I have a patient with organophosphate poisoning and I've confirmed it either from clinical grounds with the support of lab in the form of decreased pseudocholinesterase activity or toxicological screen confirming it, how will I manage? So any patient of poisoning should be managed in 2 or 3 steps. The first step is decontamination, right? So decontamination means getting rid of the ongoing exposure to the toxin, and then antidote if it exists, and then third, management of complications, right? So how do I decontaminate? We have to remove the patient from ongoing exposure. So if it is like a farmer who has gone to the field to spray, and there someone recognizes him that he is having some toxicity symptoms, right? So you have to first take him out from that area where he was spraying, because he will continue to inhale, and organophosphate compounds can be absorbed transcutaneously through inhaled route as well as oral route. So even inhalation, falling of the poison on the skin, or oral intake, all can cause toxicity. So you should first be separated from the site where the poison exists. Okay, if it has already taken inside the body, it has to be brought out, right? So how can we do that? So first thing is skin decontamination. Why? Many times what happens is when patients drink organophosphate poison, it smells yuck, probably tastes yuck. So while trying to drink larger quantities, they spill it onto their body. So even the cutaneous exposure, if the patient continues to wear the same cloth, there will be ongoing cutaneous exposure. So as soon as we get a patient of organophosphate poisoning patients, remove all clothes, right? We have to remove the clothes. It doesn't mean that make him stay clothless. Of course, you will make him wear some hospital gown or clothes, but the clothes which are contaminated or soiled, they will continue to give cutaneous exposure. So that has to be removed. In fact, I remember a case from my internship where we had a patient who, to scare the family members that I'm attempting a suicide, he had just sprayed, thinking that spraying on the skin will not cause any problem. Only consumption causes a problem. He had sprayed the organophosphate compound on his skin and he had presented, but he had severe signs of toxicity. Okay, gastric decontamination can be done by gastric lavage or activated charcoal. Okay, both of these need to be done very carefully. So at a PG level, it's a debatable topic, gastric lavage or activated charcoal use, because there's a risk of aspiration, needs to be done carefully. Okay. Now, once the decontamination is done, it's time to administer antidote. So what is the antidote for organophosphate poisoning? So the first and the most important, or actually the only important antidote, is the atropine. Atropine. Okay. And then there is one more which actually reactivates the acetylcholine esterase, which has been potentially inhibited by the organophosphate compounds, right? The acetylcholine esterase reactivator, which is pralidoxime. Pralidoxime, which is also written as P2AM. P2AM refers to pralidoxime. Pralidoxime. What is it? It is the acetylcholine esterase or enzyme reactivator. It is the acetylcholine esterase reactivator. In your pharmacology, you study that atropine and P2AM are both useful, but in clinical medicine, we would say pralidoxime's use is debatable. Most of the studies done in last 10 years say that pyrrolidine use is not beneficial and it may be associated with harm. So benefit though nahi hai in the recent studies, harm is there. So I personally do not use pyrrolidine for organophosphate poisoning patients. WHO still continues to recommend use. So if you write also right, it is okay. If you don't write also, it is okay. But atropine, you can't miss. That is the drug of choice. Okay. Atropine. It is the antidote of choice or drug of choice. When is it indicated? It is indicated for all patients, right? Then we have something called as atropine target. So earlier they used to say the target of atropinization is go on giving atropine till all the signs of organophosphate poisoning is or toxicity is reversed. Then the guidelines revised and they used to say that try to maintain. What kills these patients? It is mainly the bradycardia and respiratory paralysis, right? So try to maintain heart rate more than 100 and make sure patient does not have fasciculations and excessive secretions. But more recent evidence suggests that we don't have to aim for heart rate more than 100. A heart rate more than 80 is more than enough, because I just want to maintain sufficient stroke volume or sufficient cardiac output, right, by maintaining a decent heart rate. So the target right now, better to write for the exam is heart rate of more than or equal to 80 per minute, right? Decreased secretions from the orifices and fasciculations. That is our target, right? Till that is achieved, we have to keep atropinizing and then we have to give maintenance atropine till the impact of the organophosphate poison goes away. Okay. Now what complications I can expect? Complications of organophosphate poisoning. The complications of organophosphate poisoning, the first one is respiratory paralysis. Respiratory paralysis requiring mechanical ventilatory support, right? And it can contribute to death. Requiring mechanical ventilatory support. And then second, it can lead to bradycardia, bradyarrhythmias, again that can become a reason for death. So respiratory paralysis and bradycardia, bradyarrhythmias are the leading causes for death in patients with organophosphate poisoning. Okay. Apart from that, organophosphate poisoning can also lead to OP-induced delayed neuropathy. So many patients of organophosphate poisoning with severe or critical illness who survive or recover, they continue to have bilateral symmetrical polyneuropathy. So they will have a lot of weaknesses and mainly the distal weakness and some degree of sensory losses persisting for several months to several years. Okay, so this is about organophosphate poisoning. Okay. Next we'll go to aluminium phosphide. Okay. The next poison is aluminium phosphide. It is not aluminium phosphate. Aluminium phosphide, usually written as ALP. It is one of those poisons where mortality rate is very, very high. It's much more higher than the organophosphate poisoning. And many a times we have lost innocent lives because people think like, where is this aluminium phosphide available? Aluminium phosphide is available as aluminium phosphide is used as fumigant for storage of grains and it is used as pesticide for rats and other pests. So it is a rat poison, used as a rat poison as well as fumigant. What is a fumigant? Fumigant is something that releases gas slowly and it is a toxic gas. So what farmers used to do is aluminium phosphide, they put into the places where they store the grains so that it releases gas slowly, and that gas, if any organism is infesting the grains, it will kill it. and when the grains need to be used for consumption, they will remove the organ of the aluminum phosphide and discard it, or mostly it would have been already converted to gas, so that when you take the grains, it is no longer existing there. And thinking that it is a not so toxic substance, many times people consume it mainly to threaten the family members or for whatever ulterior motives they have, and then they end up losing their life because it is highly toxic, right? Why is it toxic? Because once we take aluminum phosphide and it is exposed to moisture, it gets converted to a gas called as phosphine gas, and this phosphine gas is highly toxic. Phosphine gas is highly toxic. What it does, it inhibits the cytochromes E oxidase. So basically, the oxidative phosphorylation or generation of ATPs that is happening in the cells is like stalled, resulting in cellular hypoxia. So all those tissues which are highly active and they need constant supply of ATPs or cellular energy, they will start losing their function, right? And one such organ is heart. So most of the patients with aluminum phosphide poisoning eventually end up with profound hypotension or shock because cardiac muscle dysfunction. Why muscles are not functioning? Because their cellular metabolism is completely shut by this phosphine gas. So what are the clinical features I expect these patients to present with? First and the most important thing, of course, mild, any toxicological case, you can of course write nausea, vomiting, and abdominal pain. You can write it for any of the toxicological case. Then after some time, you start noticing that these patients have profound hypotension or shock. Profound hypotension or shock. Majority of them die because of this hypotension or shock. Third thing, because the tissues are in hypotension or shock, the tissue perfusion is poor, and thus they are switching to anaerobic metabolism from aerobic, and we will end up getting metabolic acidosis, profound metabolic acidosis. Okay. Fourth, as the condition progresses, patients can start throwing up seizures, and eventually it can lead to coma as well, right? And it is associated with very high mortality rate compared to most other common poisoning cases. Okay. So if I am suspecting a case as having aluminum phosphide poisoning, right? What investigations I will do? Okay. So first thing is aluminum phosphide. You will get to know if the patient says that, sir, I have taken this, right? That in most toxicological cases, we get to know what is the reason for the toxicity when patient brings the carton from which the stuff has been consumed. Otherwise, we have to rely on the toxicological screens or lab tests, right? So most aluminum phosphide cases are diagnosed because of the history rather than the lab investigations. But if I have to do a lab investigation, there are some investigations. One of them is silver nitrate impregnated paper test. Either we can do it on patient breath or the gastric content, which is either aspirated or vomited. Or we can do the gas chromatography to recognize the phosphine gas or the aluminum phosphide. Okay. But we also need to do other general investigations because most importantly, we have to identify all these complications happening, right? So what investigations I will do? I require serum electrolytes. I will require RFT, LFT. Okay. I will require serum lactate levels. Serum lactate levels will be elevated in patients with aluminum phosphide poisoning because the tissues are switching to anaerobic metabolism. And then acid base analysis using the arterial blood gases to recognize the metabolic acidosis. So these are additional investigation, but for specific confirmation, we are doing gas chromatography or silver nitrate impregnated paper test on the gastric content or breath. So now once I have identified that this patient is having aluminum phosphide poisoning, right? How do I treat it? Unfortunately, there is no specific treatment or antidote for the treatment of aluminum phosphide poisoning. There's nothing proven to antagonize the impact of phosphine gas on the cellular metabolism. So what we can do, it's always about supportive care. So decontamination, of course, yes. Decontamination is not very helpful in most cases. Why? Because as soon as the aluminum phosphide goes into the stomach, it will come in contact with the gastric moisture of the gastric juices, and it will start releasing the phosphine gas, which is again quickly reabsorbed into the systemic circulation. So that's why activated charcoal or gastric emissaries are not found to be very useful. Okay. What else we can do? Infusing larger quantity of oil through the Ryle's tube into the stomach has shown some degree of slowing down of the release of the phosphine gas. But again, on large scale studies, no benefit proven. So what we do? As of now, the evidence exists only in supportive care. What supportive care? Treat the complications that arise. If patient goes into shock, resuscitate with fluids, use inotropes. Right, if patient develops metabolic acidosis, try to aggressively correct it to maintain the pH in the safe zone. With that, some patients you may be able to say, majority will end up losing as of now. So management primarily focuses on supportive care. There is no specific antidote. No specific antidote. And then, so when I say supportive care, right, what I can do for supportive care? So a patient is in a state of shock, I can treat it with fluid resuscitation and inotropes. Fluid resuscitation and inotropes. A patient is having metabolic acidosis. How can I treat it? I can treat it with sodium bicarbonate infusions. So that's all we can do. There is no specific antidote. We had an antidote for the organophosphate poisoning. Okay, cool. The next poisoning we're talking about is paracetamol poisoning. Okay. Paracetamol is one of the common mode of poisoning or common mode of attempted suicide in the urban areas. In the rustic rural areas, it is usually organophosphate poisoning, but paracetamol poisoning is very common in the urban setting, right? So now paracetamol poisoning can occur either due to inadvertent excess consumption, or it can be due to excess consumption because of suicidal intention. Okay. Now, what dose of paracetamol is acceptable as therapeutic dose? The therapeutic dose of paracetamol is less than 4 grams per day, 4 grams per day, and out of that it should be less than 1 gram, less than or equal to 1 gram per dose. So at any given point of time, we should not be giving more than 1 gram of paracetamol to anybody. So in post-operative cases and all, we do give up to 1 gram of paracetamol as IV infusion in a single dose. In a given day, we should not exceed more than 4 grams. That is therapeutic dose. Okay. As doses start exceeding 4 grams, the hepatotoxicity can start showing up. But there is also something called as toxic dose. So the toxic dose is usually 10 grams per day. 10 grams per day, and the doses high in the form of like 25 grams is considered as lethal dose. So if someone takes 25 grams in a single dose, it can be lethal, and which is very common because you take 2 strips of Dolo 650, right? We will exceed the toxic dose. 3 or 4 strips, we will be at the lethal dose. And because it is not a regulated drug, readily available, no pharmacist will ask you why are you taking 4 strips of Dolo 650. Many patients do attempt suicide with paracetamol. Okay. Now, what toxicity paracetamol causes? Toxicity or clinical features. So paracetamol primarily affects liver. The toxicity is paracetamol is hepatotoxic. Hepatotoxic. So what it will cause? It will lead to increase in AST and ALT. and ALT in mild toxicity, but in profound toxicity, right, in severe cases, it can lead to fulminant liver failure, or you can also call it as acute liver failure. Now, what is the meaning of acute liver failure? The development of hepatic encephalopathy in a patient with the liver dysfunction in a very short span of time, right? So acute liver failure patients often will develop hepatic encephalopathy. So once someone has taken very lethal dose of paracetamol, eventually he will have hepatic encephalopathy, coagulopathy. That is because we know that vitamin K dependent coagulation factors are produced by liver. So if liver is not functioning properly, then we will not be able to generate factors 2, 7, 9, 10, and we will tend to bleed. So coagulopathy, encephalopathy in a patient with liver dysfunction, we will call it as liver failure. If it is acute, it is acute liver failure, right? Now, more precisely, what hepatotoxicity I would see, right? It causes centrilobular necrosis. Centrilobular necrosis. In terms of MCQs, they will ask which zone. It causes zone 3 necrosis. Zone 3 necrosis. So that is the toxicity. So most patients who have been exposed to toxic or lethal dose of paracetamol will have some degree of liver involvement. So if I get a suspected case of paracetamol poisoning, right, how will I manage? Management of paracetamol poisoning. What is the antidote for paracetamol poisoning? So to understand the antidote for paracetamol poisoning, we have to understand how paracetamol is metabolized in the liver and why higher doses cause toxicity. So normally what happens is paracetamol is metabolized by the conjugation reactions, that is basically glucuronation. So when paracetamol goes to liver, it gets glucuronated and then it gets eliminated. 90% of the paracetamol is metabolized that way, and 10% of the paracetamol is metabolized by an alternate pathway which leads to formation of a compound called as NAPQI. Okay, so I will show you the chart that will give you an idea. So normally what happens, 90% of the paracetamol gets conjugated with glucuronide moieties to give rise to non-toxic glucuronide metabolites, which will be eliminated. But 10% through cytochrome P450, a subvariant called as 2E1, gets converted to NAPQI. This is highly toxic. This is the one which is causing the centrilobular necrosis. But normal individual paracetamol doesn't cause this problem because whatever NAPQI that is generated, it gets converted to non-toxic substances quickly with the help of glutathione. But if you're taken toxic doses or the lethal doses, so the amount of paracetamol entered this route increases because this glucuronation pathway gets saturated and more paracetamol gets diverted to the cytochrome P450 pathway, and then NAPQI generate is very high, and your glutathione reserve in the body may not be sufficient to convert all of that NAPQI to non-toxic, and thus this NAPQI starts causing the liver injury. Clear? So that is the mechanism. So if you want, you can write, right? It is due to metabolite called as NAPQI, metabolite called as NAPQI. So now if I have a patient of suspected paracetamol poisoning, how will I manage? Remember, the antidote is N-acetylcysteine, but we do not give it for all patients. I have to decide whom to give and whom not to give. Right? Of course, before that there is decontamination. Decontamination will be in the form of gastric lavage and activated charcoal. Right? Decontamination will be in the form of gastric lavage or activated charcoal. So whatever paracetamol that is unabsorbed, which is still there in the stomach, can be removed through gastric lavage, and activated charcoal can facilitate absorption of the paracetamol. Then Antidote is N-acetyl cysteine, NAC. N-acetyl cysteine. Okay, how N-acetyl cysteine is going to work? Basically, N-acetyl cysteine provides glutathione, right? It becomes a precursor for glutathione. So basically, by giving N-acetyl cysteine, we are making more and more glutathione in the body, so that whatever toxic NAPQI that is been generated is all getting converted to non-toxic, and the risk of liver injury declines. So that's why N-acetyl cysteine is our drug of choice. But it is indicated only for selected patients, right? When is it indicated? Indicated for PCT patients whose serum paracetamol levels. So basically we check serum paracetamol levels taken at 4 hours or after 4 hours or later after consumption falls above treatment line on. I will try to explain what does this mean, but at least let us first write it down. Rumac Matthew nomogram. Rumac Matthew nomogram. What does that mean? See, remember, the risk of liver injury is dependent on your blood levels of paracetamol. They correlate. Higher the blood levels, like if it is more than 300, there is a high chance that there will be some degree of liver injury. Lower the blood levels of paracetamol, there will be low chance of liver injury. So it's not only dependent on the dose, because it's also dependent on the absorption rate, absorption kinetics. Some people will absorb more, some people will absorb slowly. So we have to mainly look at the blood paracetamol levels. Right now, blood paracetamol level is a function of time, right? If I take a now, like let us say I have got headache and I take a paracetamol. After how many hours my headache gets relieved? Usually 1 to 2 hours, right? So the peak blood levels of paracetamol when someone takes the non-toxic dose, the normal dose of paracetamol, the peak blood levels are reached at around 2 hours. That's why most of our pain gets better by 2 hours. The peak blood levels are reached by 4 hours if it is higher than the normal dose. Right? So if I check somebody's paracetamol levels half an hour after taking the paracetamol, the peak blood level might not have reached. So I'm not seeing the true high level, right? I'm seeing relatively low level now, but after 2 hours, 3 hours, it is going to rise, right? So that is why we will take the sample only at 4 hours or later. If patient is presented already after 4 hours, anytime he presents, I can take. But peak is seen after 4 hours, right? After that, the paracetamol level may go on decreasing. So then how will I decide? So for that decision, we have a graphical representation of the serum paracetamol levels on a scale which is called as Rumac-Matthew nomogram. So it looks like this. So on one side, we have hours after ingestion, right? Like 4 hours after consumption, 8 hours after consumption, 12 hours, 16, 20, 24, right? And then on another axis, the y-axis, we have the acetaminophen or paracetamol levels plotted. Okay, and in this nomogram, we see two lines. Okay, one is intermittent dots, other one is continuous line. The continuous line is called as treatment line, and one intermittent line is called as Rumac-Matthew line. So what Rumac-Matthew did was, he plotted serum paracetamol levels and the risk of liver injury. And then he came out with this line saying that anyone whose serum paracetamol level at any point of time, right, they fall on the right side or above this Rumac-Matthew line is at risk of paracetamol induced hepatotoxicity, and he requires treatment. Okay. Now to account for lab variations and other factors, another line was drawn which is slightly below this Rumac-Matthew line, and now we call this as treatment line. So any paracetamol value taken any time after the consumption, if it falls above this treatment line, we need to give N-acetyl cysteine. Now when you look at this nomogram, the lines begin after 4 hours, because within 4 hours we would not have reached the peak paracetamol level, so we will not be even checking it or doing anything, right? We will check only after 4 hours. and the line halts at 24 hours, right? Why is it halting at 24 hours? Because after 24 hours, giving N-acetylcysteine is not beneficial. If I'm starting, I should start within 24 hours. Whether I need it or not, I will decide based on where the patient's serum paracetamol levels fall, right? Let us say I got a patient whose serum paracetamol I'm checking 8 hours after consumption. Here, 8 hours after consumption, and let me say it is 80, right? So here is where 80 I can find. 8 hours after consumption, 80 falls above the treatment line. So that means this patient needs treatment. He is at risk of the liver injury, right? I get another patient after 16 hours and his value is, let me say, 10. So it falls here. It is below the treatment line. So this patient does not require N-acetylcysteine. So in the exam, what I should write? Of course, you can try to draw the image of the nomogram. No, need not mention the numbers. You can mention time in hours in one axis, that is x-axis, and on y-axis you can mention serum paracetamol levels or acetaminophen levels. Okay, and then you can say here it is 4 hours, here it is 24 hours. Draw a line which is actually segregating, which begins at 4 hours and ends at 24 hours, somewhere from high to down like this. One more line just above that. The above line you call it as Rumac-Matthew line. Rumac-Matthew line. And another line you label it as the treatment line, and then mention that N-acetylcysteine should be started for any patient whose serum acetaminophen levels fall above treatment line. Okay, so that completes our description of when to initiate the antidote, right? Antidote is N-acetylcysteine, when to initiate. Now the dose of antidote, right? The dose of antidote. So N-acetylcysteine, when it is given, there will be a loading dose or a bolus dose. Loading dose will be 140 milligrams per kg, right? Then after that 70 milligrams per kg, right? Every 4 hours, 15 to 20 doses. 15 to 20 doses. So first you will give 140 milligrams per kg, which is based on the patient's body weight. After that, 70 milligrams per kg you will keep giving every 4th hourly as IV infusions for total 15 to 20 doses. So the duration will run for few days. But remember, if patient is presented after 24 hours, there is no benefit, right? We don't start. If you have started before that, then I will continue for 15 to 20 doses. That's about our paracetamol poisoning. Okay, now we'll take the next question, which is on shock. The question goes like this: define shock, classify shock, describe diagnosis and management of septic shock. Okay, so what is shock? The common notion is that shock is equal to hypotension, which is wrong. Hypotension is not equal to shock. Shock is not equal to hypotension. So what is shock? We will define shock like this. It's a form of cellular, means cell level or tissue level hypoxia. Cellular or tissue level hypoxia, which is due to many mechanisms are possible. Either decreased tissue delivery of oxygen, right, or increased oxygen consumption by the tissues, or inadequate utilization of the oxygen by the tissues. Means tissues are either not getting sufficient, or they need more than usual, or they're getting sufficient, they need as much as the normal, but they're not able to utilize it, or a combination of these factors, right? Most common cause for shock is circulatory failure presenting as hypotension. So BP in patients with shock need not always be low. In fact, BP in patients with shock may be low, that is hypotension, normal, or it can even be high. So just because somebody's BP is not low, shock is not ruled out. So shock in simple words is tissue hypoperfusion, pushing the tissues to suffer from hypoxic consequences. So hypotension is not equal to shock. Hypotension is not equal to shock, or shock is not equal to hypotension. So shock is a circulatory dysfunction where tissues or cells are experiencing hypoxia, which can either be because of reduced oxygen being given to tissues, or increased oxygen demand by the tissues, or inadequate utilization of the oxygen by the tissues. Okay. So now, how do I classify the shock? The shock will be classified into 4 groups. The first one is cardiogenic, second obstructive, third hypovolemic, and fourth is distributive shock. Okay. So first we will address cardiogenic shock. What is cardiogenic shock? So tissue hypoperfusion can happen if heart is not pumping efficiently so that the blood reaches the tissues, because oxygen is reaching the tissue through blood. So cardiogenic shock is a condition where there is decreased tissue delivery of oxygen because heart is not able to pump efficiently, right? So what can be the cause for cardiogenic shock? What can be the cause for cardiogenic shock? So in the cardiogenic shock, there is decreased cardiac output, right? There is decreased cardiac output resulting in tissue hypoperfusion, and the cause for this decreased cardiac output is a cardiovascular cause, right? So causes for cardiogenic shock include myocardial infarction, right? Myocardial infarction. So suddenly if I develop a massive MI, right, whole of my left ventricle is not getting blood supply. So will it be able to contract well, eject well, and give the blood supply to my tissues? No. Of course, I will have hypotension here, right? But hypotension is not required for all forms of shock. Where else I can have? I can have in patients with acute heart failure, right? Acute decompensated heart failure. I can also have cardiogenic shock when I have acute MR or acute aortic regurgitation. So these are all conditions where I can have cardiogenic shock. Okay. Then we have obstructive shock. What is this obstructive shock? It is a condition where the heart functions are getting impaired so that it is not able to generate good cardiac output because of obstruction in the surroundings. What can be the obstructive factor? It can be like the massive pericardial effusion giving rise to cardiac arrest. So in that case, the sufficient blood is not reaching the heart itself because the right ventricle is getting compressed. So if less blood comes to the right ventricle, less blood will go to the lungs, less blood will go to the left side of the heart, less blood will come out from the left ventricle. So in obstructive shock, there is impaired cardiac filling or ejection by obstructive causes. Example I can quote is cardiac tamponade. Okay. Now next is hypovolemic shock. Even hypertrophic obstructive cardiomyopathy is one such example where there is obstructive shock. If someone is having HOCM, there is obstruction to the left ventricular ejection. The left ventricle's function per se is not affected. Left ventricle is able to do its job, but when it contracts to eject the blood, the obstruction is restricting the ejection. Okay. Then hypovolemic shock is where there is either blood loss or severe dehydration, which is resulting in decreased circulating blood volume. And remember, circulating blood volume is a determinant of BP. So if decreased circulating blood volume means there will be decreased blood pressure, and that will result in tissue hypoperfusion. So here heart is fine, nothing is obstructing the heart, its function is fine. but circulating blood volume itself is low because of blood loss or dehydration. So most of the surgical cases, post-operative shock are generally because of hypovolemia. Okay. Then we have one more called as distributive. So we have cardiogenic, obstructive, hypovolemic, and distributive. So what is this distributive shock? So now normally heart contracts, like let us say this is my heart. Okay. And then I eject the blood from the left ventricle to aorta. I receive the blood to the right atrium from the superior vena cava and inferior vena cava. The blood comes to right ventricle. From the right ventricle, blood goes to pulmonary artery. And the pulmonary artery will take it to the lungs. And from the lungs, the blood will come to left atrium. From the left atrium to left ventricle and then to aorta. This is how we circulate. Okay. Now in the cardiogenic shock, the left ventricle or cardiac muscle is not able to function. It's not able to contract. So that is why the amount of blood ejected into the aorta is coming down. Cardiac output is getting down. So the tissue perfusion, the blood reaching the tissues is down. So we have shock. In obstructive, either something is obstructing the ejection from the left ventricle or filling of the right side of the heart, resulting in decreased cardiac output. That's a possibility. Okay. Now, in hypovolemic, the amount of blood that is circulating itself is going down. What is happening in distributive shock? So as I eject the blood from aorta, right, it will pass through various blood vessels to reach tissues, and from the tissues, the blood will come back through veins to the heart. Okay. Now, if I dilate these distal small blood vessels, instead of the previous small size, I dilate them. Then what will be the outcome? If I dilate them, the outcome is, as Boyle had said, the pressure and volume are inversely related. So if I dilate these peripheral blood vessels, the pressure inside the peripheral blood vessel decreases, right? So when I dilate, peripheral vasodilatation results in decreased peripheral vascular resistance. Why the resistance is decreased? Because the pressure inside them is decreased. So now what will happen? The blood ejected by the heart generally flows from higher to lower pressure zone. Now these blood vessels are dilated, right? They are at very low pressure. So more and more blood will get pooled in these peripheral dilated blood vessels. And once the blood gets pooled in these peripheral dilated blood vessels, it is not returning back to the circulation. As long as these blood vessels remain dilated, they are at very low pressure, so blood stays there. So this much of blood is now eliminated from the circulation, right? So what will happen then? Blood pressure will drop. Why this is happening? Because of peripheral vasodilatation. Large amount of blood is getting pooled in your peripheral blood vessels, right? Just to give you an example, not an example, but an analogy. During school prayers, a lot of kids faint, right? Why do they faint? Because on prolonged standing, the blood gets pooled in the lower limb veins, the calf veins, because of gravity. So that much blood is not part of your active circulation. So amount of blood available for heart to pump to brain is slightly decreased because blood is getting pooled in your calf veins because of gravity. So brain perfusion decreases, patient faints. Once the pain can fall down, the gravity's impact on the calf muscles is eliminated, blood comes back to circulation and things get better, right? So same thing is happening here. When peripheral blood vessels get dilated, some amount of blood gets pooled in those dilated peripheral blood vessels and patient can have hypotension, right? And once there is hypotension, tissue hypoperfusion, so I will call it as shock. So these cases where peripheral vasodilatation is causing redistribution of blood to the peripheries instead of keeping it in the core central circulation, we will call it as distributive shock, because blood is getting distributed to the peripheries instead of keeping it in the central circulation. So peripheral shock is due to decreased peripheral vascular resistance, or you can say peripheral vasodilatation. Peripheral vasodilatation. Examples for this? The examples for the distributive shock are septic shock and another very famous, well familiar to most of us, anaphylactic shock. Anaphylactic shock and septic shock. These are classical examples for distributive shock. So what happens in septic shock? In septic shock, there is peripheral vasodilatation. So all the blood is getting pulled towards the periphery, less in the core, main blood vessels, hypotension, shock. Anaphylactic shock, same. Peripheral vasodilatation, blood getting distributed to peripheries. Central circulating blood volume is down. You will have hypotension and shock. So these are the types of shock. So among these, which shocks are more common? Distributive is very common. Septic shock and anaphylactic shock are common. Hypovolemic shock is very common. Cardiogenic shock is also very common. Obstructive shock is relatively rare. So in a patient, how will I differentiate between different types of shock? Okay, few things will help us. One easy tool that will help us to differentiate between the distributive and other types of shock is the temperature of the extremities. So in all other conditions, right, when there is, let us say, hypovolemic shock or cardiogenic shock or obstructive shock, your BP is going down. What body will do when BP goes down? It will activate renin, angiotensin, aldosterone system and sympathetic nervous system, right? So what RAS will do? RAS has angiotensin 2 and aldosterone. Okay, so forget about aldosterone for now because it is going to work on sodium and water. But angiotensin 2, what it will cause? It will cause vasoconstriction. So whenever BP is going down, body will have a vasoconstrictive response, right? Then hypotension will also activate not only RAS, but it will also activate sympathetic nervous system, right? And what sympathetic nervous system will cause? It will also cause vasoconstriction. So if blood vessels are constricted, less blood is coming to your extremities. What will be the temperature of the extremities? See, why our body parts feel warm? Because the circulating blood is bringing the heat to the body parts. So basically heat is generated where? Heat is generated at the tissue level because of the metabolism, right? When we burn glucose to generate ATP, we are also generating heat. When we are utilizing ETPs to do any function in the cell, we are generating heat. That heat needs to be lost from the body. So blood is the medium to do. So blood brings the heat from the tissues, mainly the core organs, to the peripheries. And then we will lose it to the atmosphere. So if less blood comes to our peripheral body parts, right, then there will be less temperature because it is the blood which is bringing that heat from the core of the body to the surface. So if there is vasoconstriction, the extremities will be very cold. But in case of distributive shock, what is happening? There will be vasodilatation. So when there is vasodilatation, extremities will remain warm, or in fact they may be more warm than normal. So that is one tool that helps us to differentiate the temperature of extremities. In hypovolemic, it will be cold because there will be vasoconstriction. Cardiogenic, it will be cold because there will be vasoconstriction. Obstructive will also be cold. But in case of distributive shock, it will be warm because there is, contrary to vasoconstriction, there will be vasodilatation. Next is, we can also look at the jugular venous pressure or JVP. Okay, so what will happen to JVP in different types of shock? Hypovolemic, there will be low JVP. Distributive, there will be low JVP. Why low JVP in distributive? Because the circulating blood volume is down. The amount of blood coming to right atrium is down. Most of the blood is in the peripheries where there is peripheral vasodilatation happening. So JVP will be low in hypovolemic, distributive, but it will be high in cardiogenic. Why it will be high in cardiogenic? Because cardiac dysfunction, right? If right, like heart is not able to eject, the blood is more pooling in the heart. So the pressures inside the cardiac chambers increase, and if there is increase in the right atrial pressure, it will reflect on the JVP. Right? In the obstructive also it will be high because entry of blood to the right side of the heart is being restricted. It is staying in the veins, right? So veins pressure will be high. So JVP will also be high. So in cardiogenic and obstructive, you will have high JVP. In hypovolemic and distributive, you will have low JVP. Another thing that we can do to differentiate between the different types of shock is raising the leg passively. So if I raise the leg of the individual, what will happen to BP? Normally what happens, because of gravity, some amount of blood is pulled into the lower limb calf veins. So if I raise it, I'm helping emptying of those veins to the circulation. So all the blood pulled in the lower limb veins comes to the circulation and BP increases. That's a normal scenario. To some extent, minimal. In hypovolemic shock, if I raise, what will happen to BP? Of course, it will increase. Why it will increase? Because already low volume, BP is low. By raising the leg, I am adding more volume to circulation, so BP will increase, right? In distributive shock also it will increase because peripheral diversion of blood, so circulating volume is low. By raising, I am adding more volume to it, so BP will increase. But in case of cardiogenic, it will not have any impact. Why? Because here the BP is low because heart is not able to contract and eject. So even if I add more blood, it will still not be able to contract and eject. So it will be low. It will not have any effect. In obstructive also, this will not have any effect because in obstructive, something is obstructing filling of the heart or ejection from the heart. So by giving more blood, it will not reach the heart easily or come out of the heart easily. So it will not have impact. Okay. Then of course, echocardiography can help us to conclude more on the different types of shock. So in case of hypovolemic, the ventricles and inferior vena cava, right? They will be relatively in collapse state because less filling of the ventricle, less filling of the inferior vena cava. So inferior vena cava will be collapsed. On the other hand, in distributive also circulating volume is less, so inferior vena cava will be collapsed, but it will be dilated in cardiogenic and obstructive. And in terms of force of contraction of the ventricles, hypovolemic and distributive, there will be increased force of contraction. It will be decreased in cardiogenic, that's why we have shock, and it will be normal in the obstructive. So this table, key points you have to write is the peripheries or extremities, whether it will be cold or warm, and JVP, whether it will be raised or not. So that kind of satisfies the examiner. If rest of the points you can remember and write, well and good. So that completes our different types of shock. Now coming to the recognition of shock. How do I recognize that an individual is in shock? So I can recognize shock if patient is having hypotension. Second, if he is having cold extremities, because that indicates that there is peripheral vasoconstriction or tissue hypoperfusion. But we have to remember that warm can be seen in distributive shock. So just cold extremities, warm extremities does not rule out shock. But cold, it's most likely suggestive, right? But there is a third clue. What is that? That is serum lactate levels. High serum lactate levels in a patient whose BP is low. Is suggestive of shock. Why? Where is the lactate generated? Lactate generated when we metabolize glucose, right? When is it generated? If we are doing aerobic metabolism of glucose, whatever lactate we generate, we reutilize, we burn for further generation of ATPs, finally leaving behind carbon dioxide and water. But if we are in anaerobic metabolism, our metabolic process halts at the formation of lactate. Further steps do not happen. So elevated lactate indicates that tissues are at anaerobic metabolism. And when tissues go into anaerobic metabolism, when either inadequate oxygen delivery is happening, or they are not able to use oxygen, right, or their oxygen requirement has increased. So that meets our shock definition, right? So serum lactate levels elevated in a patient with hypotension is highly suggestive of shock. So this is how we recognize a shock. Now once we recognize the shock, how do we manage? The management of shock depends on the underlying cause. So first thing you should mention is treat underlying cause. This is very, very important because if there is a hypovolemic shock, I have to replace the fluids in the body. If it is cardiogenic shock, right, let us say there is a patient with MI. The force of ventricular contraction will not improve until and unless I re-establish the blood flow by doing the coronary angioplasty. Right. If there is an obstructive shock, until and unless obstruction is raised, like let us say there is a patient in cardiac tamponade, until and unless I put a needle and drain out the pericardial fluid, I will not expect the improvement in shock. So treating the underlying cause is very, very important. Okay. So how do I treat? Just to give some examples, right? So it is like pericardiocentesis for cardiac tamponade, and then if it is a case of ECG, acute coronary syndrome or MI, then I can do percutaneous transdominal coronary angioplasty, PTCA, if it is a case of acute coronary syndromes, right? Inotropes for acute heart failure. So treating the underlying cause is important. Second, fluid resuscitation. Where is this useful? Only two types of shock it is useful: for hypovolemic shock patients and distributive, right? These are the two types of shock where there is fluid deficit. Otherwise, cardiogenic and patients with okay, cardiogenic and cardiogenic and obstructive shock. In those cases, there is inadequate handling of the fluids. Adding more fluid will worsen the condition. So we should not be overzealously giving fluids if we are dealing with shock, right? So, and distributive shock patients. And then you can mention a word saying careful fluid management for cardiogenic and obstructive shock. And third, to improve the BP, you can also consider inotropic agents. That is the general management of shock. Now coming to the next component. Mandip Kumar, see, for snake, we have anti-snake venom. Now, there are different types of snakes. We have neurotoxic snakes, we have hemotoxic snakes, we have myotoxic snakes, and some snakes can share neurotoxicity as well as hemotoxicity. Hemotoxic snake bite leads to impaired blood coagulation and increased risk of bleeding and death. Neurotoxic snake bite leads to neuromuscular paralysis, paralysis of respiratory muscles, hypoxia, and death. So in the Western world, what they follow is they have specific antidotes for specific snake. Like if it is cobra, there is a specific antidote. If it is crate, there is a specific antidote. If it is Russell's viper, there is a specific antidote. In India, what we follow is polyvalent anti-snake venom. Means the common toxic snakes that are encountered in India, that is cobra, crate, and vipers, mainly the Russell's viper, is covered in that anti-snake venom. So we just give that, provided there is signs of toxicity. What are the signs of toxicity? Either hemotoxicity, which can be assessed as 20-minute whole blood clotting time, means at 20 minutes of taking a blood out from a patient, if it is still not clotting, that means there is hemotoxicity. Clot should form within 20 minutes. Or a patient is having ptosis or other neuromuscular paralysis findings in such cases. Or if there is an ongoing bleeding from the bite site which is not stopping, that means there is significant envenomation. In that case, we go ahead and give anti-snake venom. Okay. Apart from that, of course, there is a role for supportive care. If patient is developing respiratory paralysis, they will require ventilator support. If there is hemotoxicity and there is ongoing blood loss, we may require blood transfusion. So there is supportive care. There is no drug per se. Anti-snake venom is the only thing that we can offer, which is specific to snake bite. And in India, what we have is polyvalent anti-snake venom. So now coming to the question that we were talking about. So we have understood different types of shock. Few things to be addressed is septic shock. Examiners generally tend to ask you to write more about septic shock if it is medicine paper, and if it is surgery paper, they ask you to write more about the hypovolemic shock. Right? So we'll focus on sepsis and septic shock. So what is sepsis? What is sepsis? Can anybody tell me what is sepsis? Is sepsis means severe infection, or sepsis means infection spreading to blood? No, that is septicemia. When bacteria start circulating in the blood or infection starts propagating through the blood, it is septicemia, or you can say bacteremia. That is not sepsis. So what is sepsis? For sepsis, we have a criteria well laid out, which is called as sepsis 3 criteria. Right? Sepsis 3 criteria. The criteria name is called as sepsis 3. So what it says, sepsis is defined as presence of organ dysfunction in a patient who is having infection. So when infection goes to blood, it is septicemia. But when infection goes to blood and then starts causing dysfunction of various organs, then it is sepsis. So we will define it as suspected or confirmed infection, suspected or confirmed infection plus acute rise in a score called a SOFA score by more than or equal to 2. This is the definition of sepsis. The criteria name is sepsis 3 criteria. I will elaborate on it. What does that mean? Okay. So in any patient where infection is well documented already, or you're suspecting that patient may be having infection, in them, if organs start getting affected, right, we will start seeing the organ dysfunction findings. And conceptually, that is sepsis, infection leading to organ dysfunction. But that organ dysfunction has to be quantified. That quantification comes from this SOFA score, which stands for sepsis related or sequential organ failure assessment score. Sepsis related sequential organ failure assessment score. So we are primarily looking at respiratory system, coagulation system, hepatic function, cardiovascular function, CNS, kidneys, right? So these are the organs we are looking at. And for those organ tests, like I will be doing for the respiratory system, I'll be looking at PaO2 by FiO2 ratio. Remember, same parameter we used for ARDS to assess hypoxia. Coagulation system, I will assess by looking at the platelet count. Liver functions, I will assess by looking at the bilirubin. Cardiovascular function, I will assess by looking at the blood pressure, from which I can calculate the mean arterial pressure. And CNS, I will look at the GCS score. Renal functions, I will look at the serum creatinine levels and urine output. So if these get altered, I will start giving scores according to the values. So if patient gets at least 2 points because of any of these organ alteration, then we will call it as. So from this score, patient needs 2 points. For a normal individual, the SOFA score is 0 because all of your organs are working fine. So from 0, it jumps by 2 because let us say your creatinine is increased to a value where I can give 2 points. So your SOFA score is now jumped by 2. Well, now you have sepsis. Now what if already I have kidney dysfunction? Again, that's why I said acute rise in SOFA score. So let us say your baseline SOFA score was 2 because your creatinine was in this range. Now that has increased higher after the sepsis or after the infection, and now your score, baseline score would have been 2. After the infection, score has become 4. So again, acute rise in the SOFA score by 2 points. So then again, it will be called as sepsis. So sepsis, we will define it as suspected or confirmed infection with acute rise in SOFA score by more than or equal to 2 points. That is sepsis. Okay. Now then what is septic shock? Septic shock will be defined as in a patient with suspected or confirmed infection. In a patient with suspected or confirmed infection, if their mean arterial pressure is less than or equal to 65 millimeters of mercury, or there is need for, and this we should write, despite fluid resuscitation. I'll brief it. What does that mean? Despite fluid resuscitation, or need for inotropes to maintain, MAP more than 65 millimeters of mercury, or serum lactate levels normal. Okay, so what is the meaning of this? Let us say I have a patient where I am suspecting that patient may be having infection. Okay, and because of infection there will be little bit of vasodilatation, peripheral pooling of blood, BP will drop, right? A type of distributive shock. Of course, at that point of time, how will I try to treat? I will give fluids. Once I give fluids, if the BP gets normalized and mean arterial pressure becomes 65 plus, then I will not call it as septic shock. It was like sepsis resuscitated with fluids. But despite my attempts to give adequate fluids, still I'm not able to get the BP sufficient enough to get a map of 65 plus. Then I will call it as septic shock. Or in those patients where after I gave fluids, the map was not maintained and I had to give inotropes to get the map to normal value or to get the lactate to normal value, will be called as septic shock. Now, why lactate is important here? Because if BP is appearing normal, that does not rule out shock. Remember, shock is tissue hypoperfusion, tissue hypoxia. Shock is not hypotension always. So your inotropes may be able to maintain your BP, but still because of peripheral vasodilatation, tissue perfusion may not be adequate and your tissues still may be suffering from hypoxia. In that case, they will be in anaerobic respiration. It is still a case of shock. So if inotropes are required to maintain lactate level to normal range or your map to normal range, it will be still considered as shock. So if there is inotropes which are required, it is still shock. Okay. Now in a septic shock patient, how will I manage? Management of septic shock. So examiner may ask you to write management of septic shock more specifically. So how will I manage septic shock? First thing is about fluid. Remember, we have already studied about shock and we know that septic shock is a type of distributive shock, right? Where there is peripheral vasodilatation and more blood is getting pulled into the periphery. And what we learn in a distributive shock, there is circulating blood volume is low. That's why JVP is low, right? But because of peripheral vasodilatation, extremities are warm. And in such patients, if I do a passive leg raise, normally BP increases. So that means if I add more fluids to the circulation, BP gets better. So there is a role of giving fluids here, right? There is a role of giving fluids. So then fluid resuscitation is a very, very important part of management of septic shock. What I have to write in the exam paper is what fluid I want to give, right? And what should be the initial bolus. And after that, how will I decide how much more to give? All that we need to write. The fluid of choice, initial bolus. Right? So the fluid of choice is going to be, there are so many types of fluids. There are crystalloids and colloids. Among the crystalloids, there are balanced crystalloids and unbalanced crystalloids. So what will we give? So for fluid resuscitation, fluid of choice is going to be crystalloids. Now, what is a balanced crystalloid and what is an unbalanced crystalloid? Sodium chloride is a crystalloid, right? Your saline, normal saline is a crystalloid, but it is called as unbalanced crystalloid. Why? Because it only contains sodium and chloride. Does it have potassium, lactate, and other substances that are normally seen, normal composition of the plasma? Does it mimic or try to match? No, right? Then I can give albumin, which is a colloid, right? I can give some complex starches, hydroxyethyl starch, which is a colloid. So what is recommended here? It is crystalloid but balanced. Example for balanced crystalloid is Ringer's lactate or isolite M, isolite P. These are balanced crystalloids. The fluid of choice is generally balanced crystalloid. It's not dextrose normal saline or normal saline. It is a balanced crystalloid. Example, Ringer's lactate or isolite. Okay. Then how much I should give? 30 ml per kg as bolus. Followed by, when I say bolus, that is over 1 hour, followed by further resuscitation guided by urine output, right? IVC collapsibility, capillary refill time. Okay, these are complex terms. You may not be able to understand now. Just write that, okay, initially we give 30 ml per kg as bolus within 1 hour. That is like if I have a 50 kg person, 1.5 liters of fluid I might need to rush in 1 hour. After that, I will have a maintenance fluid which will be decided by looking at patient's hydration status, which I can gauge by looking at whether IVC is dilated or collapsing, whether patient's urine output is adequate or still low. So those factors are a little complicated, but at least be able to mention the initial thing. Okay, so that is about fluid resuscitation. Second, it is a septic shock, right? So it calls for antibiotics. So antibiotics, should I wait for the blood cultures? No, antibiotics should be empirical. Empirical antibiotics, preferably broad spectrum, and antibiotics to be started within 1 hour of patient's presentation. The more I delay the antibiotics, more profound the septic shock will become. Why? Because why is the shock happening? Because of peripheral vasodilatation. Why there is peripheral vasodilatation? Because when we have infection, right, mostly gram-negative organisms are likely to cause septic shock in comparison to gram-positives. Gram-positives can also, but more commonly gram-negatives. Why? Because endotoxins, the lipopolysaccharides and other cell wall components of these bacteria will be circulating in the blood. In response to that, body produces large amount of inflammatory cytokines. These inflammatory cytokines cause endothelial injury, and endothelial injury results in release of nitric oxide, which is a vasodilator, which will go and cause vasodilatation of your peripheral blood vessels. So if I have to halt this whole cycle, the root cause is infection, right? The bacteria are triggering your inflammatory cytokines. So if I cut down the bacterial load, inflammatory cytokine load will also come down. So endothelial injury will also come down, nitric oxide generation will come down, and vasodilatation will come down, shock will get better. So antibiotic has to be given within 1 hour. Don't wait for culture and all. It is empirical. Of course, you don't know the organism most likely at the time of presentation. So keep using broad spectrum antibiotics. Once the culture reports come, you can step down from the high antibiotics that you would have started initially, right? The third thing is, despite this, you may not be able to get good BP and tissue perfusion, so you might require inotropic agents. Again, what examiner is looking for here? In the inotropic agents, examiner is primarily looking for what is the inotropic agent of choice, right? So the preferred inotropic agent, if I have to use for a patient with septic shock, preferred agent will be noradrenaline. I can consider using adrenaline also, but noradrenaline is the preferred agent, or it is the inotropic agent of choice for a patient with septic shock, or for that matter, except cardiogenic shock. If I need to use inotropic agent, we generally prefer using noradrenaline. For cardiogenic shock, where force of contraction of the heart has come down, we use the inotropic agents like dobutamine. So if you want, you can just remember the drug of choice for the inotropic agent of choice for cardiogenic shock is dobutamine. Just a note, so that if they instead ask you to write about cardiogenic shock, then you can mention inotropic agent of choice for cardiogenic shock is going to be dobutamine. So that's about the management of shock. So that completes the two major emergency medicine questions, which is poisonings and shock and subtypes of the shock. The dog bite, snake bite, and scorpion things can be 5 marks questions. So that is covered in the MedEd Farre note. So you can definitely go through that. If you have any doubts related to the protocols or management, you can ping me on the Telegram. I will address that. So I'll conclude the class for now. Tomorrow we will be discussing endocrine. Remember guys, for most of the medicine papers, when I look at majority of the universities, larger number of questions are coming from endocrine comparison to any other systems, including the neuro as well as cardio. The simple reason is the endocrine diseases are a bigger burden on the society than the neurological disorders or cardiovascular disorders. They tend to ask a lot of questions. So tomorrow we will be discussing. Tomorrow's session may stretch for 3 to 4 hours to cover the entire endocrine questions. So I'll see you tomorrow at 6 p.m. Till then, see you. Bye-bye.